wanted to show you some of the anatomy, and then we're also going to see the actual injections on a real person. So when you're looking at the skull and you're looking at the muscles, and then look at the patient and try to have 3D vision and see. But truly, and I teach, and we both teach for Allergan. And I always tell all the new injectors, buy yourself a skeleton head on Amazon, because you really need to become familiar with where the bones are. Because the first set of fillers, Juvederm Ultra and Ultra Plus from 20 years ago, they were very hydrophilic, which means they swelled a lot. There were no other indications of nasolabial fold, so everybody would only inject the nasolabial fold, and everybody walked around like this, right? We all remember that? And then that's kind of where fillers got a bad name. But over the last 20 years, now we have 8 different types of fillers, and they differ in their rheology, which is the way the filler reacts in the body. And so one of the qualities is how hydrophilic it is, meaning how swollen it'll get or how much water it'll absorb. So the newer ones absorb less water. So we can filter correction and be confident that what we're putting in is going to look the same the next day as you go on. The older ones we had to undertreat because they would swell up a lot. And so it was kind of a guessing game for patients. So we can do a little bit more kind of fine tuning now. Also, how cohesive the filler is. So think about like a very low cohesive filler would be almost like syrup, where more cohesive filler is like a gel or even like a gummy bear almost. So stiffer, and so it's going to stay where it is better. And those more cohesive fillers are the structural fillers, and that's where the anatomy comes in, because the structural fillers we don't want to put into the skin because it's just going to weigh the skin down. And you've all seen people who've had filler in their cheeks, but they look very heavy, right? And that's where that filler is put in that wrong location. The structural fillers, the Volux and the Voluma, we're putting right onto the bone. And because what we want to do is extend that skeleton framework to hold the skin up. So when we do this patient here, and you look at the skeleton, there's her cheekbone, her mandible, and jawline. And so we're going to put some deep filler in this area, and what that's going to do is help lift that skin up. So not weigh it down, but lift it up. And then you're going to, if you look at the soft tissue, and that's where the folds and wrinkles are, that's where you put the thinner fillers, so the less cohesive fillers, the ones that are smoothing fillers. And those we're going to put more superficial, and those help smooth those lines. So structural fillers deeper, and smoothing fillers more superficial. Any questions about that? So that's filler. And then you want to talk about Botox?
So, there's been a big trend, as you said, to the lower face having its moment. And it's a little bit more complex in addressing the lower face and jaw because it often isn't just a one-size-fits-all answer. If a patient comes in and they're like, I don't like these lines, there's one answer and it's Botox. When we're dealing with the lower face, not only do we lose the dermal components of skin and structure with collagen, elastin, and hyaluronic acid, which help to keep the skin surface tight, we also resorb bone. And so the whole framework of the face is kind of shrinking, and subsequently we have wrinkling of the canvas. So we have to address the jawline with filler. We have these hyperdynamic platysmal bands, which is the most superficial muscle on the body. When we're in gross anatomy and trying to dissect that away, it's very hard to even get it away from the skin. That's how superficial it is. And it attaches all the way up here on the face, so it can pull down over time. So when we inject along the platysmal bands, we also inject at the base of the mandible to kind of give a net effect of a lift. And so we also have to address skin quality. Sometimes a lot of people have either sun damage or crepiness of the skin of the neck. And so that might be a light-based device or a radiofrequency device in order to help with skin texture. So it's a multi-pronged approach to the lower face, but we will see when we inject along the mandible to help give more framework to the jaw that the neck often follows suit and looks better. So this is the newest indication that Botox has, and we have been doing it a lot, but it's all kind of following suit of what we've seen for the past several years of like going from the selfie where everyone knew their angle, they knew their side, they knew their look, and it was a very static image, to then all of a sudden when you're seeing yourself animate on video conferencing, it's like, oh my gosh, I made that face, I never knew my jawline looked like that. Where we see Ozempic face is typically through the mid face with atrophy of the central fat pad and then migration down, which happens over time anyway, but it just is accelerated with any large volume weight loss. So that's where we'll help to like volumize through the mid-face in order to help with that. And that's typically where we use Voluma.
But it's a good question though, because it happens sometimes when we do liposuction of the neck. So somebody have a heavier, thicker neck, but smooth skin. And then we liposuction it, and then now they say, what are these vertical lines here? And like, that's your muscle. So it's kind of, I say it's like when the tide is covering the beach, it looks nice and smooth, and then the tide goes away and you see what's under the beach. So if we take away that fat, now you're going to see what's underneath of that fat, and then you can see the lines. So that is a phenomenon, but a lot of times like with liposuction, like I was saying.